I have a pre-recorded presentation from Emily Timothy, who had a career development grant with the Burwood Academy last year and did some really interesting work looking at how early vocational rehabilitation can be addressed through multidisciplinary teams on rehabilitation wards. So without any further ado, I'll hand over to Julianne Johns.
Thank you, Johnny. Just sharing my screen. How's that looking for everybody?
That's great, Julianne.
Great, excellent. Well, first of all, kia ora tātou. Thank you very much for having me today. I'm a research assistant here at Burwood Academy and very pleased to be able to bring the voices of some of the people living with pain and spinal cord injury in Aotearoa, New Zealand to you all. Aptly named, as we'll discover, I've taught my doctor well. Just like to acknowledge that the initial project was funded by a CMRF grant, Canterbury Medical Research Foundation, had ethical approval from the University of Otago, and was undertaken in collaboration with the University of Otago researchers and advisors with BAT, Burwood Academy. I'd also like to make particular thanks and acknowledgement to the 6 wonderful people who participated in these workshops with us, and I'll talk more to that a wee bit later on. To set the scene, what do we know about spinal cord injury and pain, bloody pain, tiring pain, as Brian said? Well, up to nearly 80% of people experiencing spinal cord injury have pain, and for a very long time. Many management options fail to provide adequate relief and exacerbate co-occurring factors in the individual's pain experience. And the New Zealand Spinal Cord Injury Action Plan evaluation that was undertaken by Burwood Academy on behalf of ACC a few years ago identified issues with accessing pain services, recommended a review of those services across the care continuum. And so it's the voices of the participants in that evaluation that really provided the impetus for this study. So on hearing those voices, we set about co-designing pain management for spinal cord injury in an exploratory qualitative study. We had 2 interactive face-to-face workshops, one in person and one online for those that didn't live in Otatahi, Christchurch. In the presentation, I'll describe the nature of the workshops and how they developed, and then outline 5 themes that we drew from careful listening to the voices of these participants and a broad inductive thematic analysis of those transcripts of the audio recordings of the workshops. And from there, I'll identify 3 aspects related to journeying on the river of pain that we might take forward as we do consider how to better shape pain management service provision for people with spinal cord injury. Our initial inquiry that we took to our participants was, how would you like to receive pain services in terms of mode, what platform people would like them delivered on, and the nature of that delivery. In preparing for the workshop, we drew very broadly on the notion of the pain journey as a river, as a point of reflection and visual metaphor. We drew on the Kawa model. It was originally developed as a professional development tool for Japanese occupational therapists, which views the individual and their experience as part of a wider context, an integral part of that, and a collective, and it brings in visual metaphors such as water and rocks, driftwood and spaces to denote ease and life flow, barriers and facilitators, and the environmental milieu when considering a particular life journey. So we presented the group members with this visual image for joint reference, and as the conversation developed, we were able to draw out key elements that they felt both supported and impeded their pain journey. So while the study was undertaken with a view to co-designing better spinal cord pain rehab services, the conversation as it happened was less about platforms and modes of delivery. Rather, the participants shared the story of their pain and pain management experiences and journeys. And we discovered that under their own sails, all had learned to live with their pain. They had to do it themselves. And so from these conversations, we were then able to glean a sense of the supports and the foundations that might improve pain management services for people with spinal cord injury right across the lifespan. I do want to stress that our participants may have come to live with pain and through their own trials and labours learned what supports them with that pain. It really never goes away. It's real, it's diverse, episodic, and sometimes it's more salient than others. Sometimes it's perilous. And above all, it really, really hurts, as you can see from some of the quotes here. Pins and needles, tearing your fingernails off, electric shocks and buzzing. So our first theme, participants really highlighted that pain is uniquely experienced and requires, as a result, unique management. Each person's going to feel it completely differently, managed, accepted, exacerbated or mitigated by complex interactions with that person's physical, emotional, social and vocational factors and contexts. And chief amongst it are the ramifications of living with spinal cord injury itself. So this person here, you can see emphasises, was looking for a more responsive and individualised approach from the providers rather than having everything lumped in under the neuropathic pain category, and instead of really listening to what she had to say. A number of the participants also identified that opioids that are often prescribed as a first-line treatment for neuropathic pain, common after spinal cord injury, not only inadequately manage that pain and its consequences, but other types of spinal cord pain response, such as dysreflexia. After weaning off opioids, Brian, and it's not his real name, learned that a decade of medication at the prescriptive ceiling had no better palliative effect in terms of pain experience, but a significant reduction in life participation and advancement due to his, in his words, foggy thinking and a lack of sobriety. And the opioids were thought to frequently exacerbate the burden of pain. And Ross built on that, saying, one thing that's grossly underestimated by clinicians is when you take pain relief always has side effects. And so the group talked about side effects such as constipation and fatigue, respiratory issues, and feeling like a zombie, which can in themselves make pain and quality of life experience that much worse. We learned also that one's perception of pain has a complex relationship with already existing pressures and comorbidities, which when addressed themselves also alleviate pain equal to or more so than medication. Participants tended to recognise that pain is always there after spinal cord injury, and its salience in someone's life is influenced by context and personal factors. So as an example, minimising the unrelenting burdens of bowel self-care with the introduction of colostomy, managing sleep, apnea, and so reducing fatigue and stress. These things helped Andrew live with his pain, as did breathing techniques, and that was far more than the prescription medications that put him in what he called a lazy river of malaise. Other participants mentioned work environments, family situations, aging, character and mood as having a complex interrelationship with pain. But all participants had experienced clinicians ratcheting up those pain medications as the first and sometimes single line approach without a real holistic assessment of that person's unique experience or an exploration of contributing factors and alternative approaches. So they all identified a more bespoke, individualised approach to managing their pain. And that leads us to the second theme, the need for choice and personal empowerment. People with spinal cord injury really look for opportunities to make decisions about a range of strategies that on balance best address their unique pain experience in order to live well with pain. So you can see in this image there's a number of different packages on this pain boat, and similarly this participant had a number of different things that they employed in order to manage their pain. You'll see reference to not only medication but meditation, wheelchair yoga, going to the gym and using the hand cycle, his own character, his own independence, his own desire to be in control, and also involving himself or moving his psychology away from pain onto more pleasant activities. So all participants were very realistic about pain as a constant in their life, whether in the foreground or the background. They were all very independently minded people, able, and used everything in their means to research and identify and trial and advocate for pain for management options that may help them, but not because they didn't want support keenly, and not from a place that we can consider equitable in relation to those that held power of knowledge, power of funds, and permission to use those management options. So if we think about empowerment, it's not so much being told you're in charge, over to you, you have autonomy, and so you are empowered. Really, empowerment comes from having resources and options that enable considered choice and access to those. And this is what our participants would like. They also want services that enable them to take an active role in collaborative decision making, services that recognise them as experts in their own bodies, their own lives and pain experience, and able to choose what best meets their needs. Desiree said she'd had to fight for it the way it happened. William said it's always me having to be proactive. And sorry, I'll just move something. One other person was talking about if they hadn't advocated for themselves, they would have been nowhere effectively. And that person really shows us that because people are themselves proactive, it doesn't mean that they are or have been empowered by the health environment to manage their pain in a way that best meets their needs. And we need to think about too, those for all sorts of reasons are not in a position to be proactive. And that's something we really need to consider as we reflect on the next few themes, which relate to access, wayfinding, and partnership. Oops, my apologies. I've just dropped out for a moment.
We can see your screen, Julianne. It's good.
That's good. I've just lost my view, so I will just take a moment to see if I can get that one back up. Apologies. There we go. Thanks for your patience. So the third theme that came out, there are three more themes, and I'll touch particularly on two. Third theme really relates to timely and responsive access. So if we think about the post-spinal cord injury lifespan, it's a long one for many, and as pain persists across that lifespan in ways that are episodic and diverse and as I've mentioned, deeply impactful and sometimes perilous ways, people with spinal cord injury really need timely and responsive access to the information and services right across that lifespan and across the continuum from acute care to life in the community. So we've already talked about there being complex interactions between pain and a range of aspects that are both ongoing and episodic. And we could also think about in addition, aging and equipment and the physiological impact of spinal cord injury itself that have gradual and cumulative effects on someone's pain experience and management needs. These might require vigilance and understanding along with quite variable inputs. And as this particular participant alludes to, there's a real need to start early and continue to be available over time, because it's a long haul journey, and they were looking for an opportunity to be able to check in and out with pain management services over time. I'll just touch briefly on a fourth theme that came through, clear navigation, because it's something that, you know, so often comes up when we talk about health services and won't be news to anybody probably. All participants in this study had really good skills in finding information and resources to support themselves, but they still found the process really nebulous, quite weighted against them. And this highlights the almost impossible task in front of those with spinal cord injury and without those kinds of skills and resources. Most of the participants reported feeling quite impeded or uncertain as they sought to understand and manage their pain. And while acknowledging that they might not be in a position to retain all the information, in the initial stages especially, most really agreed that having an early introduction to pain, particularly as a really common secondary complication of spinal cord injury, and getting a bit of a preview of pain management options and services and pathways in the rehab setting would really promote their clarity and ability to more effectively navigate the health system in the years following their spinal cord injury. And the last theme really underpins almost every other theme, and that is of partnerships with and between health professionals, and we'll see also with others. These participants often feel like they're on a river of pain alone, but they value collaboration in almost every area. And you can see from this quote, the person who provided our title quote, "I've taught my doctor well," they were really proactive in researching and teaching their GP about spinal cord injury pain, but so valued their willingness to paddle alongside them and learn together, put their heads together. Partnerships between spinal cord and pain specialist teams so that they could share and integrate their respective kitties of knowledge related to spinal cord pain was suggested, and also the need for those spinal cord and pain specialists to support the knowledge of generalists like GPs and acute medical teams was also seen as really crucial. And then there's the value of partnering with others with lived experience that can't be really understated. Those that have navigated a river of pain on their own have so much to offer. And this could be through online, local and global forums, networking opportunities, peer groups and mentoring. And we can see that this person here really felt it was a huge part of their learning journey as they came to accept and learn how to live with their own pain. So on hearing this, what could we take forward with us as we think about improving pain management for people with spinal cord injury? So if we think about journeying on a river again, three things come up. The first is we need to launch early. And in this space, as we launch into the river, there is a place for preparation for pain as that secondary complication. This is where the education of between specialists and of MDTs might occur as well, and an in-reach perhaps into the more acute and subacute rehab settings. It's where somebody might be introduced to the possibilities around management options, even if they might not be able to take them all on at that time. It's where an initial community pain pathway and potential supports for an individual might start, and where they might initiate an individual pain plan. And then once we've launched, we need to ride the river bringing with us resources to use as needed and maps to guide the way and companions to share the journey. So in this space, there might be a repository of knowledge or a pain portal, if you like, for people with lived experience, their whānau and health professionals that they're working with. It might hold a range of strategies or research and information around alternative medications or pharmaceutical options, case studies and videos, and also a referral process that it could guide them. Here too, there might be some supports and resources related to communicating with others, to funders and services, that incorporates templates and appropriate language and structure, perhaps, to really capture the attention of those that they need to listen to them. And links to peer support forums, whether it's local or global. And here, while riding the river, we hope that they will have with them whānau who are also supported in the way that they might be. And then lastly, we have the riverbank and the floor of the river, which is a context or a place that allows for flow and spaciousness in the pain journey, where there are responsive environmental and people-based supports, one where others could gather and oversee and encourage the journey. So it could be also a place just to be free to rest as well for a while off the pain boat, just while participating in other aspects of life. So this could be thought of as a docking bay, perhaps, and a place where it can be recognised that pain is not always in the foreground. It can go into the background for a while, and a rest off the pain boat's required. And I think it would be important for this rest to be able to be taken without prejudice or loss of renewed support as and when it next comes to the foreground. So to bring it all together, we recognise that the pain journey for people with spinal cord injury is more of a braided river. It's constantly in greater or lesser flow. It's highly complex, changeable, and it's one carved out and navigated by each in a unique way on their own pain boat. It needs ready points of access from its source all the way along. It requires clear and cohesive navigational support, and it can't be sustainably journeyed alone. So if we bear this in mind as we think about improving pain management services for people with spinal cord injury, and if we support an early launch, a safe journey with supporters in the pain boat and on the banks, we might find that river reshaped with more flow and space and supports for the unique life that it holds. And I just finally want to really acknowledge that much like a river is carved out over time, so too, as we all know, is the translation of knowledge to practice, of the voices of our workshop participants into tangible actions by others. And I want to thank our participants very much for their faith in our mahi, our work, their patience, and to acknowledge their very real hopes that these messages will reach those that might collaborate with them to greatly improve the management of their pain and others living with spinal cord injury. So it's a great honour to bring that to you today. Thank you very much for listening.
Kia ora, Julianne. Fantastic presentation. I'm always surprised at, well, not surprised, but reminded how much pain occupies the lives of people, not only the people with spinal cord injury, but their whānau as well. Did you find any participants had any reflections on how it affected whānau?
Yes, I'm thinking of a discussion. I haven't got the quote exactly, but basically, if it happens to us, it happens to the family. And it also was alluded to when I talked about how there's a complex interrelationship with pain and the wider context that the individual is living in with their life. So, you know, if the family is under stress, that can exacerbate a pain experience, and likewise watching a loved one be in terrible pain is hugely impactful for family. There's a sense of hopelessness and helplessness. So that was definitely mentioned, and the need to support the family was raised by those experiencing pain themselves. Yes.
Thank you.
Julianne, can I just get you to stop sharing your screen?
Oh,
and
yes.
then, because I can get ready for the next one while you're answering questions.
There we go. All set? Great.
Yeah, I think we've probably got time for one or two questions. If anyone would like to ask Julianne anything, just remember to take your microphone off mute.
There's a wee chat from Hans. He might be too shy to say his bit, or he's eating.
He might be having his.
Julianne, thanks so much. I learned some really important things today. Kathy, does it align with
Always shy, says Hans. I haven't seen the other.
Kathy and Jen in particular, I'm interested, is this what you kind of see in clinical practice, as the findings resonate with what you hear from people?
I'm waiting for Jen, but
I'm waiting for you, Kathy.
I can't see, so I can't kind of.
You go first.
Oh, well, firstly, I'm really sorry. I had a few technical issues, but finding a pathway to get on the topic. But yeah, from where I sort of hooked in, really interesting. Thank you, Jen. Yeah, and I guess as a physio working in the community with folk who have spinal cord injury, it can be challenging to know the pathways to sort of tap into for resources. And I actually, just while you were chatting, I was looking, there was a really good resource I'd found that New South Wales had put together. I think I heard of it at one of the conferences, and I'm not sure if at the start of the talk there was anything around sort of resources people had tapped into or found for themselves. And Julianne, was there?
Was it, sorry?
Oh no, they're just the ACI. Sorry, you go.
I was just tuning back into the initial part of your question. You said at the start of the presentation, was there any reference to
resources that people might have been tapping into themselves?
Only indirectly. For example, people talking about having gone online and finding out things that they would take to their GP. No specific reference, if I recall, from our discussions around specific resources, but going to articles, trying to empower themselves with knowledge and learning about different medications, and also finding those global forums useful.
And sorry, and I may have missed this, but what is there sort of a pathway? The plan is to have a pathway developed, or
our plan at the moment is that would be a useful thing. We're going to be looking at some more research, hopefully, or applying for more research opportunities in the future. But at this stage, I wouldn't say there is a plan to develop one. But it's
yeah, I know. I agree. I was just thinking that in the New Zealand context, and probably for Jen and I and perhaps others on here, we probably are in a privileged position where we can tap into the resources that we have here in Christchurch, whether that be through pain management or spinal, having that handy, but obviously much more difficult coming from a provider perspective in perhaps communities where those resources aren't available, trying to find things for folk that you're working with, or helping sort of partner them and directing them in directions. Yeah. So I was just, that I often use this resource from New South Wales that ACI put together that's online that people can go into. It's for health professionals as well as for folk with pain themselves, and they've got a pathway sort of for people with spinal cord injury pain. And so that's, I found that a really useful tool. But yeah.
We've got a hands up from Hands.
Right, am I live?
Yes, indeed.
Thank you. I'm just going to try and lower my hand. There we go, hand lowered. Julianne, outstanding presentation. Thank you again. Empathy comes from understanding, and understanding the other person's perspective. And I particularly found a lot of value in the quotations that you had of people's experience of pain. When you speak with people that don't have spinal cord impairments, but maybe are wanting to support the work that we do at the Spinal Trust, when you say pain, I'm sure many of them think of the time they kicked the tow bar on with their shin and they're in a lot of pain, or their kid pinched them or punched them or poked their eye, and pain is often seen as something that is here for a moment and then is gone. But yours, I think, was one of your quotes, I felt like my foot was going to explode.
Yes.
And that was just an eye-opener for me. I've never heard ever heard anybody express that before. So I'll be having an offline chat with you, but whether or not we can use any of your information to share with others so they have a greater understanding of what does it really mean when my work colleague says I'm having pain issues today. It's not just I've got achy bones or I've got a headache. It could be I feel like my feet are going to blow out the bottom of my wheelchair, and it's so distracting I can't do my work properly. I mean, that's quite a different experience. So thank you. It was very, very worthwhile. Thank you.
Thanks, Hans.
Julianne, I've got a question, which maybe for you, maybe for Connie, maybe for Rochelle, anybody. That all the work that's done at the Burwood Academy really is driving towards some kind of knowledge translation. And I'm just wondering where you see this going in that formal process, or whether anyone has any views about how it might be moved along.
We're working on a paper at the moment based on this. Well, this is what the paper is based on, and hope to be able to submit that in the next few months. And that's where, in terms of my role, that's as far as I can speak to. But I wonder if you, Rochelle, would have any thoughts about where it might go in terms of Burwood Academy.
Yeah, well, certainly other ways of disseminating the knowledge, like Hans just suggested, being able to work in with New Zealand Spinal Trust, their peer supporters, for instance, that are working, offering potentially some training for peer supporters, making sure that there's information, really good tips. For instance, something could be done around pain. So there's that way we can contribute. But also, as Julianne mentioned, we would seriously like to explore some sort of health service delivery type of project where we use this information to design some aspect of the pathway. And our initial discussions have been, we kind of need to, we think, have more, there needs to be something that happens earlier on around setting a stage for pain. Setting a stage for discussion, increasing the confidence of clinicians in talking with people about pain, because it seems to be one of those taboo topics that people avoid because they don't want to make it worse. And so we wonder whether a focus, and this is where it would be really great to hear Jen and Kathy and the New Zealand Spinal Trust's view, but whether something, focusing on that launching early phase might be a something we could work on initially.
Thank you.
It's Jen here, Rochelle. But coming from the perspective of working with people with spinal cord injury, but also working within a company that does a lot of pain management services, what I find is that number one, people with spinal cord injury do get referred to the pain management services, but the pain that people that spinal cord injury patients have is different to what the majority of pain management services can offer the spinal patient. It's a different pathway of pain. Quite often it's the neuropathic pain. It can be pain from the organs rather than that musculoskeletal pain that turns into a chronic disorder that then the patient stops moving and gets deconditioned and gets a fear avoidant behavior. That's really different to what our spinal patients really exhibit, and that they are living and thriving within this pain, but they just need someone to help them understand it and acknowledge it, and see if there is anything that can be done except for drugging them up with opioids or other drugs. So, I mean, I think while people believe that the current pain management services are the answer, they're not, and that we really do need a dedicated specialised pain service for people with neurological injuries who have chronic pain, rather than tapping into what is currently being provided, because it isn't a one shoe fits all, and definitely the people with spinal cord injury most of the time do not fit into the current pain management model.
Hey, thanks everybody. I'm sure we could talk about this for many more hours because it's a very, very interesting area, but just conscious of time. My last final addition to that is sometimes when you're experiencing intense pain, your world can shrink so much that you need a health system that has the least amount of barriers to navigate as well. So comments like Jen's are really, really, really insightful and important. But without further ado, Rochelle, if I could hand over to yourself to facilitate Emily Timothy's presentation. Emily's pre-recorded a presentation on multidisciplinary teams interaction. She did some observational work about early vocational rehabilitation. So, okay to hand over to you, Rochelle, for that?
Absolutely. And just to say, if people need to go, just go. This is recorded and you'll be able to catch up with it later, or we'll put the actual recording online. So sorry about the timing.
Tēnā koutou katoa. Ko Emily Timothy Tokuingua. I'm going to present the findings of an observational study that was part of a broader research project exploring early vocational rehabilitation after spinal cord injury. Early vocational rehab is a relatively novel approach to supporting people in their return to work. It refers to rehabilitation started in the early days and weeks after hospitalisation, starting in the inpatient setting. Research in this area indicates that the longer someone is on sick leave, the less likely they are to return to work. We know that early vocational rehabilitation is effective, cost-effective, inspires hope, enhances early motivation, and improves self-efficacy. What remains unclear is what exactly is early vocational rehab and how does it work with the wider team? Research to date has focused on outcomes and outlines the tasks and roles of early vocational rehab, but it's not followed early vocational rehab in action on a spinal unit, nor has it explored the influence and role of the wider team in this. When I say the wider team, I'm referring to staff like the social workers, OTs, physios, nurses, doctors, carers, health rehabilitation staff in general, who we know also are having conversations and working on things that relate to a person's work journey. So we undertook an observational study underpinned by realist evaluation. We observed rehabilitation staff sessions on a spinal cord injury unit in Christchurch. We interviewed and observed people with spinal cord injury, and we spoke with the early vocational rehabilitation staff and the wider team that were working with those people. And we tried to undertake interviews and conversations as close to the observed sessions as possible to get a real sense of what had happened, how it felt, and why people were having these conversations and what their plan was from there. We also conducted some interviews at intervals through a person's rehabilitation journey to get a sense of how things change. So we had a total of 24 participants, 7 of whom had had spinal cord injury and 24 who were staff, which included early vocational rehab staff. The people with spinal cord injury were predominantly New Zealand European and males, and their ages ranged from 24 to 63. We had 16 weeks of data collection, and during that time conducted 54 interviews and 16 observations. So I'm going to present our findings in terms of a garden analogy to represent our results. So firstly, the seed represents the person with spinal cord injury who holds all the potential for returning to work. And it was immediately clear that the entire team, including the early vocational rehab staff, required an understanding of the person as a whole. And it quickly became clear that this understanding echoed to Whare Tapawhā model of health in terms of understanding the physical needs of a person, social, mental and spiritual needs. Similarly, rehabilitation staff, including the vocational rehab team, needed to understand and adapt to the changing weather of external contexts such as changing health needs, financial uncertainty, or housing uncertainty. This understanding that of the individual seed would influence when and how work conversations would occur. The soil represents how the team provided the required nutrients to the person with spinal cord injury. So the entire team would maintain a person's sense of work identity, foster hope for return to work, and optimise a person's self-efficacy. That was through both overt work conversations, but also in more subtle and impromptu ways. The early vocational rehab team would work quite flexibly, and they would explore work options and stay connected with the person with spinal cord injury, regardless of where in their work journey they were. This also included staying connected with whānau and employers as appropriate. The early vocational rehab team on this spinal cord unit sat separately from the wider rehabilitation team, but it was really important that there was still very clear communication between the two teams, and there was a clear influence between the teams so that the presence of the early vocational rehab staff influenced the wider team, and also the presence of the wider team and conversations that they had helped influence the early vocational rehab team in terms of the decisions they made and the approach they were taking in terms of work rehabilitation. Overarching and underpinning this was the assumption by everybody that work is possible if that's what a person wanted. The sun represents the overarching message of generalised hope, but both the person with spinal cord injury and the team held to various degrees at various points in time. Of course, there were sometimes stormy times for the person, especially in those early weeks and months after their spinal cord injury, but behind the clouds, often on observing and discussing, there was still this sense of hope. And often the times when people doubted themselves the most in terms of their hope for the future, that was often times when the staff would step in more and provide that generalised hope of a better future, even though it was not always clear of what that might be. So all these things would lead to what we've termed as the early work outcomes, which are considered as the roots. And importantly, sometimes these outcomes were not obviously visible, but they were still really important for laying the foundations for that person when they left hospital and continued on their journey towards work. So we found that people became engaged in work solutions. The work conversations helped with their psychological adjustment to their injury. Importantly, people gained a bigger understanding of themselves, particularly in terms of themselves in a work situation. And with that, increased their confidence in their ability to work. So for some people, this would have led to a very clear plan of how they were going to return to work. For other people, it was not clear, but there was still this overall sense of empowerment that a person gained from having these early vocational services working with them and the wider team having conversations about work with them. I just want to put all this back into realist terms and look at the overarching picture. So we can see how the understanding of the individual with spinal cord injury and those external contexts impacting a person at any moment in time, being able to understand that is really key in designing and implementing an early vocational rehab service, particularly so in the context of the wider team. We know that there are lots of activities that the early vocational rehab team do and the wider rehab team do that we can consider as the mechanisms. There's the tasks, but then there's how these translate into the way the service is received and felt and works for a person after spinal cord injury. As we've already mentioned, the roots can be considered those outcomes, and we're talking here about the early work outcomes for a person after spinal cord injury. And I'd just like to highlight how the sun, when we were doing our realist analysis, so this notion of hope, was actually seen as a recurring theme, both in terms of a contextual factor, a mechanism of effect for early work conversations, and it can also be deemed as an outcome of being able to maintain a person's sense of hope. So really key in the context and the mechanisms interacting with one another was the building of relationships of staff really understanding the person in front of them really well and being able to communicate well with that person. So without those two key things, the activities or the mechanisms of the early vocational rehab team and the wider team couldn't be effective. And with that was ultimately a sense of understanding. People often describe this really powerful feeling of being understood by the staff. And this was the, I guess, prerequisite for everything else being able to successfully occur. So, of course, there are many quotes, but I'm just going to talk through a few. So a staff member said, most people, they kind of, as they go from hope to despair, they also juggle the things that they've lost against the things they haven't lost. Part of our job, and the staff's job here, is to help people see that the things they've lost maybe are not as big as they seem, and the things that they retain maybe are more enduring or valuable than they think they are. A participant with spinal cord injury was asked, how did that feel, that conversation about work options? It's opened my eyes. I feel my brain's on fire, getting some ideas and stuff. So it sounds like it was really helpful to get their take on things. Yeah. Another participant was asked, in terms of the timing of that work conversation, how did that feel for you? It was pretty good timing actually, because it was probably when I was weighing things up, you know. Yeah, it was about the time I made my mind up, and the vocational consultant understood. So I just want to finish by focusing on how the way that early vocational rehab staff and the wider team work together influence the experience and outcome for people with spinal cord injury. So often it was seen that there was a really united approach, and that it was felt that work conversations could be prioritised by everyone, regardless of their role. And similarly, people were able to be flexible. I've mentioned already that the early vocational rehab team were more able to be flexible than the wider team, but still all of the team had some degree of flexibility of when somebody was raising work conversations, feeling like they could tailor and discuss work in an individualised way. Now, these two contexts and resulting mechanisms led to enhanced work self-efficacy, a strengthened hope for work, and maintained a person's sense of work identity, again, regardless of whether it was clear about a person's work trajectory. However, when there was a hesitant approach to work, there was a resulting lack of coherence in work conversations. And at times there was actually a conflict in what staff members were saying to a person. Now, this was not only not helpful in moving somebody towards the desired outcomes I've just mentioned, but it actually increased the uncertainty of work for the person with spinal cord injury. This kind of feeling, well, if the staff are telling me different things, then it can't be possible, you know, what chance am I going to have? So it was really confusing for people. So in conclusion, early non-pressured conversations about work were overall seen as helpful. Having a service dedicated to vocational rehabilitation, which can be flexible and prioritise a person's individual and changing needs, is important. And it's important that the entire rehabilitation team have a united approach to work conversations, and communication and influence and understanding of one another's roles was really important in that. Now, I'd just like to take a moment to thank all our participants who so generously gave their time, but were also so open to being watched and asked about their rehabilitation journey. They obviously gave a lot of time, and the staff were really open to me sitting in and watching sessions and asking about what was going on. So thank you to them, and it really has been so valuable to be able to get that insight of real time what's going on in terms of early vocational rehab and that wider team. Okay, that's all from me. Thanks very much.
Well, thanks to the pre-recorded voice of Emily Timothy. And I also wanted to acknowledge that that was part of a really, really interesting study being led by Jennifer Dunn, looking at early vocational rehabilitation for people with spinal cord injury. I realised it's 1 o'clock, but if anyone had any questions they'd like to maybe ask myself, Rochelle, or Julianne on behalf of Emily or Jen, please feel free. No, I'll take it.
In terms of the knowledge translation question, which Pauline, I'm sure would have asked, Emily's dream would be to, in a non-COVID Omicron peak time, actually, I guess, facilitate some ongoing discussions that could potentially happen between the various teams, or in some ways contribute to clarifying how could communication and coherence of messaging be increased between the early vocational service providers and the MD team, because that seems to be a key sort of risk area. So I know that's something she would love to do in the longer term. So I'm sure we have, because the Health Research Council has given us a little bit of extra, or given Emily a little bit extra money and time. She is still giving some hours to the Burwood Academy Trust for the next wee while. So yeah, do get in touch, New Zealand Spinal Trust, particularly if it's something that you would love Emily's support with, and we'll talk to Jen about the possibilities as well.
Hi, Rochelle, you can't see me because I'm secret. It's Andrew speaking. Andrew,
I did recognise your voice.
Thank you, even though I'm lying down. So I wondered that if it's getting some sort of line into the in-service training, which I'm not sure if that's going on the ward. I kind of hope it has. I've possibly been distracted with everything else going on, but to at least get a slot or two in there, and knowledge translation to those professionals. Yeah, that to me would be the logical. That's the group we're after, really.
Andrew, I'm not sure if it's going as such, but I definitely know that each professional group has some dedicated in-service training. We could actually, instead of doing to whole spinal unit, which hardly get anyone going to, it would be easier to go to each professional group. So I know PTs and OTs quite often do joint sessions, so you could go to that. You could go to a couple of nursing education sessions, and then you could present to the medical staff. I think you'd be better to target them individually as opposed to trying to get a spinal unit wide in service initially.
Yeah, well, Jen, Spinal Trust would be really happy to partner with you in delivering that, because of course Emily's focus was on the spinal unit, but there's early happening after the spinal unit, whether it's Habit Health or whomever the provider is in the community, those early arrivees back in the real world. We want to have a consistent message and a clarity around their options then too.
Yeah, and what I would say, Andrew, just from my experience even here, is that people who do VOC rehab aren't aware of what EIVR is and what the goals and outcomes are, and so it would be really useful to perhaps, we've got the preparing the soil for the inpatient teams, but we've also got that communication message to the community that we could look at improving as well.
Yep.
I was just going to say on that, because often people, well, I guess my experience has been that people are often quite focused on their rehab when they come out, and I'm really aware of that as a physio. There's sort of this, focus on that and parking VOC to the side. And what is quite challenging is when there's essentially sort of a plateauing, or in terms of functional gains or whatever, and this sort of shift to, well, what now? Particularly for some of the high level injuries who perhaps have come from more of a trade background. There's that, there's that shift in focus, and it's quite a challenging. It's quite challenging knowing how best to help in that, I guess.
Do you think we would be best targeting like TI teams as opposed to VOC teams to start with? Because most of the people are under a TI, and it's sort of, as a TI provider, you quite often get asked by the case manager when they're ready to start looking at back to work options or return to work options. So do you think it's the TI teams we need to target more than VOC, or do you think we need to target both?
I mean, probably both, but I definitely think the TI teams that are quite heavily involved, and actually people often, you know, I mean, even in physio sessions or OT sessions, people are, you know, they're raising, I've got a guy this way, you know, sort of like, what, you know, I'm not quite sure what I can be doing with my time, you know. So yeah, definitely with TI, because they're probably more heavily involved initially.
What do you think, like just knowing how many even TI providers there are in Canterbury, what sort of forum do you think we would go through to the neurosig, or would we do it more company by company? Or I'm just thinking of how we get the right people.
Yeah, what about through some of the providers forums, you know, so TI provider forums that might link in with ACC, you know?
Yep.
Yeah, I mean, neurosig's are only going to pick up more professional,
physios.
professions. Yeah.
Yep.
Yeah, I mean, there are provider forums, so that might be the best option. But I mean, obviously that's only targeting ACC ones, so.
It's great to have these discussions, and that sort of, you know, take the research to the next level. It's fantastic. One thing I would say, Jen, in response to your question about, you know, it might be easier to talk to single professional groupings, but the central issue really is about how teams work together to rehabilitation. So I would argue that actually getting them together to and kind of almost be confronted by the different attitudes and beliefs within different groupings could actually also be really helpful. But
yeah,
I
agree.
know
I wonder, like, I do know that when I was at the spinal unit, and Kathy may have been there at the time, that when we did training on talking about sexuality, that there was actually a workshop developed that different disciplines went to different workshops, but everyone was combined. And I wonder if we actually develop a workshop and actually take it to the spinal unit as a package, and say, you know, we're going to run 4 workshops at these times, and we'd like to get as much staff through that as possible, and actually just be a bit more proactive. So you're not going to get everyone there at the same time, but you'll get a good mixture. So you might get a doctor in each group and 2 or 3 physios, but that worked really well when we were doing sexuality training.
Sounds like a good plan to work with. You and I can nut that a bit more with Emily.
In our spare time.
Yeah.
Solutions, I love it.
Well, should we finish now? Johnny, have you got a karakia to end?
I've only got the one that I opened with. I don't know if it's appropriate to end. Yeah, I'm not sure. Can you do that one for an ending?
Is that training 202, not 101?
Yeah.
Say it again, because it's actually, so this is all about listening to the voices, and actually both of these presentations today have been about really listening hard to the voices and trying to hear the meaning often behind the words, and the humanity of each person that we're trying to represent in these findings. So I think it would be appropriate in this setting as my summary.
Kia ora, Rochelle. Well, it's my personal goal to remember this off by heart by the end of the year, so good things take time. Whakarongo, whakarongo, whakarongo. Ki ngā hae mano, e karanga ne tui tuia. Tui e ke rongo, tui e ke raro, tui e ke waho, tui e ke roto. Tui e te here ngā tangata katoa. Te hei uri uri, te hei nako nako, te hei Māori ora. Kia ora.
Kia ora.
Thanks everybody for
Johnny.
coming along, and
Thanks.
hopefully you took something out of those. I think looking on the poster on the wall, we might have another peer group on the 19th